Good evening, and thank you very much for attending our forum tonight. I think it's going to be a really exciting night. I hope that we're going to have a lot of conversation, a bit of controversy. Let's see what comes out of it, so feel free. As you know, this is an event run by La Trobe University as part of Melbourne Knowledge Week, which is an annual event and is a very wonderful opportunity to engage, think with the community and thinking about the big issues. And La Trobe University, when we're thinking about what we'd like to do with Melbourne Knowledge Week, we naturally thought about health because we are a leader in health, as many of you will know, a leader in health around research and in education. And so we think that we can contribute quite a bit to the discussion. All of our panellists tonight are actually associated with La Trobe University, some of them very closely, most of them very closely, and I think they show the sort of outcomes and the impacts that La Trobe University can have on people who study and work with La Trobe University, particularly around the health areas. I would like to note that we actually have a Twitter feed here, and I'm encouraging people to participate in the communications. So if you can use the hashtags hashtag MKWHealth and hashtag Knowledge City, that would be fantastic. And you can give us your feedback as we're going through. If you agree, if you disagree, if you want to make a comment of some sort, feel free. We want you to engage. I'm going to be asking the panel some questions, and they'll be coming out with some main things that they think is really important in this area of sustainable health care. But I'm going to get you also to ask questions, and that will be in the later part of the session. So get your questions ready. We're going to have some mics that will go around. When you ask your question, if you could stand up, say where you're from and who you are, and just make sure we can hear the question, that would be terrific. So I'm encouraging you to participate because that's the way you'll get the most out of it tonight. As an introduction, most of you or many of you will know that we do need to think about a sustainable healthcare system. Recent data coming out around health expenditure in Australia is rather alarming. Total expenditure on health was estimated at $154.6 billion in 2013-2014, which is up by 3.1% on 2012 and 13 in real terms. Growth in expenditure per person was $6,639, which was $94 more in real terms than in 2012 and 13. Total expenditure on health in Australia is 9.8% of GDP in 2013 and 14, which is up from the year before. Governments provide about 68% of the total health expenditure, and this represents about 25% of the total taxation revenue. So it's a massive, massive issue. The non-government sector share of total expenditure increased from 30% to 32.2% in 2013 and 14 from the year before. Funding by individuals, though, is the fastest growing area of non-government sector expenditure over the decade. So we have an issue, and it's interesting to think about how we can try and manage that. What things can we put in place? What things can we try and do or influence to make things better into the future, to make a sustainable health workforce? That's the question for tonight. Now, before I go too much further, I'm going to introduce our distinguished panel, and they have an amazing array of experiences, and that's why I'm so pleased that they're here today. So what I'm going to do first is go through each of their bios so you get a feel for their context and what they know about this area and where they're coming from. And then I'm going to get each of them to come up and tell us what they think. So first of all, I'll introduce Andrew Cameron. He's the current Director of Nursing in Birdsville, Queensland. He did a Bachelor of Nursing at La Trobe University in 1991. He was one of the first groups actually to go through our nursing program as a La Trobe student. Andrew is a highly decorated nurse and humanitarian and aid worker, recognised nationally and internationally as a leader in the nursing profession. Andrew's work has taken him to some of the world's most troubled hotspots, including Sierra Leone, the Sudan, Iraq and Afghanistan. Over 9 years, Andrew has volunteered in Afghanistan, Iraq, Kenya, the Sudan, Yemen, Ossetia and Sierra Leone. In Afghanistan, his leadership led to polio vaccination of more than 300,000 at-risk children and young adults. Most recently, Andrew worked as a manager of safe burials at the Red Cross Ebola Treatment Centre in Kenema, Sierra Leone. Andrew has long demonstrated commitment to mentoring employees, including his work in the northern mountains of Yemen, where Andrew managed camps for internally displaced people for 10 months, mentoring staff to improve the standards of medical and nursing care in camp clinics. In Australia, Andrew is a trainer or a facilitator for the Council of Remote Area Nurses, where he gives his time voluntarily to help run emergency nursing courses throughout the country. In 2011, Andrew was awarded the highest international distinction in nursing, the Florence Nightingale Medal for exceptional courage and devotion to victims of armed conflict. In 2004, he was named Australian Nurse of the Year, and in 2013 received the Medal of the Order of Australia. So welcome, Andrew. An amazing biography. The next person I'll introduce, another distinguished member of our panel, is Professor Sandra Leggett. She's the Professor of Health Services Management Course Coordinator, Director also of the Building Healthy Communities Research Focus Area at La Trobe University. Sandra joined La Trobe University Health Services Management Program in May 2002. She's had a varied career in healthcare management. Sandy started as a physiotherapist in Ontario, Canada, which you'll notice by her accent, she is Canadian, and moved through the hierarchy to become department manager and then senior manager in a number of Canadian healthcare organisations. She was Vice President Planning and Corporate Development at Baycrest Centre for Geriatric Care, Administration Director Primary Ambulation and Community Care at the Toronto Hospital, and Executive Director at the Health Station at Community Health Centre in Toronto. Sandy moved from Toronto in 1998 to become Chief Planning Officer of the Inner and Eastern Healthcare Network in Melbourne. That's when she came to Australia, of course. She's experienced as a management consultant, most recently with PricewaterhouseCoopers, but also with the Hay Group and Agnew Peckerman Associates, which is a smaller healthcare planning consulting firm. She's always enjoyed teaching, has lectured at Monash University and the University of Toronto, and of course with La Trobe University. So welcome, Sandra. And lastly, but not least, we have our last panellist, who is Professor Stephen Duckett, who's the Director of the Health Program at the Grattan Institute. Professor Stephen Duckett has held top operational and policy leadership positions in healthcare in Australia and Canada, including as Secretary of what is now the Commonwealth Department of Health. He has a reputation for creativity, evidence-based innovation and reform in areas ranging from the introduction of activity-based funding for hospitals to new systems of accountability for the safety of hospital care. An economist, he is a Fellow of the Academy of the Social Sciences in Australia. He's experienced in quality, new systems of measurement and accountability for safety of hospital care. Welcome, Stephen Duckett. Okay, now I'd like to actually call to the podium then Andrew, just so that you can give us your thoughts about this. Or you don't have to walk up here, you can stay here, that's fine.
Thanks. My perspective is from, as you just heard, working overseas. So I've come to realise that we're extremely fortunate in Australia with our healthcare system. It's extremely well funded. Everyone across the country has great access to healthcare, even in remote areas. I think the way forward, as a general rule, is re-establishment of public education on preventative means and things that we've probably let slip over the past decades. Health funding is a very complex area. There's books and books on it, and I don't profess to be an expert on it, but from a practical point of view, I've got some insights, but we can go onto that later. Thanks.
Good. Sandra.
As Karen said, I've spent a lot of my career working as a manager, working on boards in organizations, and now as an academic. And I'm particularly interested in how we lead, what we can do to develop the skills of current and future leaders in healthcare. And I was reflecting on what I wanted to say here, and I was feeling totally overwhelmed with these two gentlemen on either side of me in terms of what they've accomplished in their careers. So I was thinking about the fact that, if we had actually had this session a month or so ago, I would talk about something completely different. But because of some of the events that have happened at the beginning of this week, I wanted to actually talk a bit about quality and safety. Karen's mentioned the financial aspects of it, but I think that we actually have to think about quality and safety. And as someone who's interested in health leadership and health services management, I'm really happy when we see the rankings of the Australian healthcare system. It always gets ranked in the top for quality and safety. So if we look at the Commonwealth Fund, we're about number 4 or 5 among all the countries in the world in terms of quality and safety in our healthcare system. And that's fantastic. But then we heard about 5 babies that probably didn't need to die, that we probably could have prevented the deaths of 5 babies. And so I think about that in terms of thinking about sustainability of our healthcare system. And it's 2015, and we're still, even though we have a great healthcare system that's recognized around the world, we're still having cases where we're making mistakes and we're not correcting things, and the care is not as good as it could be. So I think my perspective on all of this is that we shouldn't get too self-righteous, that we should think about what we need to do in terms of health leadership, because we still have a ways to go. We clearly have some things that we need to do. And so I've got some opinions, I've got some ideas as to how we might think about changing or advancing our health leadership so that we never have to read about preventable deaths again.
Fantastic. Thanks, Sandra. Stephen.
Well, now I've got too many things to talk about.
We knew that.
So, first of all, I'll take issue with your introduction, Karen.
Fine.
The issue about sustainability is a really interesting one. It's an interesting word. The first 3 letters stand for sus. And when people talk about sustainability, basically you've got to be suspicious about what they're saying. As Andrew pointed out, and I agree, Australia has a very good health system. In terms of costs, we spend below our peers in terms of cost per head of population or cost as a share of gross domestic product. So we're on the right side, or the left side, but the lower cost component. In terms of life expectancy, we're above the OECD average in terms of life expectancy. So with that crude measure of outcomes, we're going well in terms of outcomes, and we're going well in terms of cost. That's not to say we can't improve, and I think we can improve, but you've always got to take people who talk about sustainability, and I'm not accusing you of this, Karen, but people who talk about sustainability often want to destroy the health system and start again, rather than saying it's an incremental improvement task that we have to be on about. It's interesting that Sandy raised the issue of Bacchus Marsh, and I was looking at that and reading about it in the paper over the last few days, and there are some. I worked in Queensland for a while, and I was hired to Queensland as part of the follow-up to the Dr. Patel, the Dr. Death scandal, which was associated with the number of people dying inappropriately. And what was interesting were the parallels. So Dr. Patel basically worked beyond his competence, but the issue with Patel was not that he was doing something wrong. It was not even that people didn't know that he was doing something wrong. He worked as a clinician, I think, in Queensland Health for 8 months. Basically, within 6 weeks of his starting, there were complaints. And there was a complaint every fortnight after he started, either from staff or from patients. So it was well known that there was something wrong. The problem with Patel was no one did anything about it. And if you look at the Bacchus Marsh story, and I've only read what's in The Age, the story is the same. There was a bullying culture. There were people who knew something was wrong and nothing actually happened. As I said, I was recruited to Queensland as part of that. The minister was sacked, the director general was sacked, more or less the entire executive was sacked, the CEO of the hospital was sacked. Not saying that's necessarily a good thing, but And part of my job was to try and change the culture in Queensland Health. And one of the ways we did that was developed a leadership development program. And we ran the largest leadership development program in the country, not in the health sector, in the country, where about, I think, 5,000 people were put through a leadership development program, which was 2 days every year. And 400 or 500 of them was a residential program, and 4,500 was a non-residential program. But what's interesting about that is, in doing so, we formed groups of the leaders. We took the leaders of a hospital and put them through the program. What was interesting about that is, in some cases, in one major teaching hospital in Brisbane, for example, the senior medical staff, the senior nursing staff and the senior admin staff had never been together in an off-site retreat, ever, in anybody's memory. And there were people there who had been working there for 40 years. So the culture of the organisation had never had a chance to interact. And so leadership and leadership programs were just so important in trying to change the culture, trying to change the way the health system dealt with mistakes and so on. And in the Bacchus Marsh case, you don't want to blame an individual doctor. It is the culture of Bacchus Marsh where something obviously has gone wrong, and that was the case in Queensland. There are two divergent sort of stories there.
Fabulous.
And we could add that it's not just Victoria and it's not just Queensland. Every state has had a similar quality and safety crisis. And so we need to be thinking about this throughout Australia, and it's about the future of a sustainable healthcare system.
So if we know that this is a problem, and it's not the first time this has happened, and we're talking about health leadership courses or sessions, what's critical in those? What's the important factors that will make a difference?
I think one of the things is that the leaders have to get out of their offices and onto the floor and talk to the people that are doing the work, the nurses, the cleaners, and the doctors and so on. A little story from the past: I trained as a midwife in a hospital about 2 blocks from here, Queen Victoria Medical Centre, which is mostly pulled down now. And I'd been there about a year, and I hadn't seen the matron, they called it in those days. So I took the bull by the horns and made an appointment to see her. I went up to her office and she ushered me in. She said, who are you? And I said, well, I'm Andrew. I've been working here for a year. I've never seen you before. I just thought I'd come and say hello. And she was quite astonished, but quite pleased as well. And we saw her on the wards once a week from then on, and it was quite refreshing, yeah.
Is this something that's particularly a problem with health, though? Do you think this is something in organisations in general?
Perhaps, but this is the area I know of, so...
I personally think it's more of an issue in health. Part of the thing is that many of our managers in healthcare don't have any management training or any leadership training, and they haven't been through a program like Queensland or a degree at La Trobe. Is that too obvious? Was that too obvious? So, I was a physiotherapist. I got promoted to be department head in an organization with no management training, and I had a staff of 30 physiotherapists that I had to supervise. It was pretty scary. My daughter's in a similar position. She's a health information manager, and she's actually now managing a bunch of clinical coders without any management experience. So it's part of the need to think about, just because we're good clinicians, which tends to be the thinking in healthcare, and we're very smart people, doesn't mean necessarily that we have the skills to be a leader or a manager. I also just want to follow up on Andrew's story, because one of the things that's absolutely amazed me, and those of you that work in hospitals might know about this now, it's this brand new thing called rounding. And what it actually is it's actually the managers figuring that they have to go to the wards, and they actually have to talk to staff, and maybe they even have to talk to patients so they know what's going on in their organization. And this is being branded as the biggest, newest quality and safety thing, rounding. And it's just basic common sense, really. Why is it so hard for us?
Apparently Henry Ford, when he had his factory producing the Model Ts, when he had 1,000 staff, he knew them all by name, and he would go down to the floor every day and say, Johnny, that little bit you're doing 100 times every day, is there any better way that you could do it? And he'd say, well, Mr. Ford, if we did it this way, we'd save a few more minutes, and the line could go faster. And he took all this on board, but he wasn't sitting up in his office and writing protocols and things. He was he was down listening to people. That's my point. So.
Okay. So, Stephen, take issue with the issues around the cost. So, do you think that we do emphasise the cost too much? Is it not expensive?
Healthcare is expensive, but you've got to think about there are basically three goals of healthcare. One is about promoting access, one is about ensuring quality, and one is about sustainability. And we've got to make sure that they're all in balance. And purely focusing on the financial side, sure, it's important, and yes, I'm one of those who talk about it all the time and think about ways of improving the efficiency of the health system, but we should never lose sight of the fact that people don't go to hospital to spend money, they go to get care or cure or whatever. It's the other parts of the health system, access and quality, are also the objects of policy that we should be talking about and thinking about.
I agree with that. So I am interested, recently in government, they've been focusing, of course, on costs of all of this. And one of the things that was quite a controversial move at one stage was the proposal to have a GP co-payment. And we saw what happened with that. What are your views on that, Stephen?
So there's actually a literature on this, and so we know what the effect of a co-payment will be. Co-payment will reduce utilisation. We know that. Co-payment will particularly impact on the poor because, $10 means more to a person on a low income than a high income. So it will reduce the utilisation of people who are poor more. Thirdly, we know that co-payment will reduce utilisation both of things that doctors think are necessary and of things that doctors think are not necessary. Or phrased another way, you can't expect a patient necessarily to know what is the right thing not to go for a doctor for and what is the wrong thing to not go to a doctor for. So utilisation will go down, yes, so we'll achieve its objectives in the short term, mainly impact on the poor, and necessary and unnecessary services will both be reduced. So then you've got to decide, is that a good thing or a bad thing? Well, my view is it was a bad thing. I think it's a very crude and inefficient way of reducing health spending. To give you another little story, this morning I had a meeting with people associated with there's a current review that the Minister Lee has set up on the Medicare benefit schedule. And basically what we were talking about this morning was about value. And there are two ways you can promote value in healthcare. One is about doing less unnecessary things, and one is to do things more efficiently. And basically we're talking about both of those, neither of which involved discussion of a co-payment. It was about getting better value for money and improving the system, but neither involved whacking patients.
Okay. Tony? Yeah, sure.
I'd like to add to the evidence too that I think the evidence is pretty clear that in addition to decreasing utilization, in addition to having larger effects on the people that possibly need healthcare most, it potentially also creates more costs for the system later on. Because if you don't get something prevented, or you don't go in when something can be easily cured, and then you go later after you've infected a whole bunch of other people, that's very drastic. I know I'm exaggerating for effect, but or if you're, if you wait till you're quite a bit sicker. So in many ways, it's a false economy in terms of thinking about copay and reducing utilization. We kind of joked about this internally, saying that the $7 that was going to go to the research fund, the researchers were going to come back with findings that clearly we already have the evidence for, that actually says by collecting the $7, the population is less well than it was before we started collecting the $7, and that's our findings of the millions of dollars that was now put into our research. So while we'd like to have the research funding, copay is probably not the way to do it.
Okay, good. So that does touch a little bit on something that Andrew started talking about and kind of heads this way. And I think it's often argued that one of the best ways of getting sustainable healthcare system and better quality outcomes is to prevent preventable diseases. So why have we let it slip, or have we let it slip? Who wants to take that one?
Well, From the past, we've had campaigns with exercise like 10,000 steps, slip, slop, slap for cancer prevention. There's been all sorts, but I think it needs to be augmented and gone ahead with, because
So why don't we do it though? Who needs to do it? What do we need to do to make it work?
federal governments, state governments,
Mm-hmm.
and that's another big issue as well.
Mhm.
Who's
Mhm.
funding what, and
Yeah.
yeah.
So is it just that we don't prioritise funding for preventative programs? Is that the problem? Sandy, what do you think?
It doesn't really fit with our political cycle. You know, governments need to have impacts in a relatively short term in terms of their mandate when they're governing. And so if you build a hospital, you can build it and you can have your pictures taken by it and you can open the hospital. If you invest in a quit smoking campaign, you're not going to see the effects, and you're not going to be able to take your picture by a really nice new building that helps you to promote what the government's done over the last couple of years. So I'm a bit of a cynic about that, but I think it's difficult because we've always got that balance between what is actually the investment that we need to make for the long-term health of the population, and in the public health system, we have short-term priorities, and it's kind of difficult to match them up.
Stephen, do you have a view on that one?
Australia has had remarkable success in prevention and public health programs, leading the world in, for example, seatbelt use. Victoria was the first country or state to do this. Tobacco control, again, remarkable success and remarkable leadership that's been shown in that area. So, and what's characteristic of both of those is they require governments to take action. They use structural change in legislation or pricing or whatever, to change behaviour. And the seatbelts, tobacco, both have led to demonstrable improvements in health status. And they're the sorts of things that we should be thinking about. What is the next generation of those sorts of changes that we should be working on? And there are some examples of that that's been done. So I think we shouldn't assume that we're not, that neither of them require big spending. So it's not the issue of spending on public health and prevention, it's actually doing things about public health and prevention.
And when we think there's, if we look at the tables that rank Australia with other healthcare systems, we're sort of number 2 in the world with skin cancer. So we have seen an awful lot of work being done in prevention with skin cancer. And so I think we can't say that hasn't happened, it's been identified. The other area is Alzheimer's and dementia. Now that's a particularly interesting area because we're still collecting the evidence on that, so we don't actually know what the programs are. But they're areas that we really need to think about for the future.
Okay. So one of the other issues that concerns me sometimes, and I'd be interested in your opinion, and particularly Andrew here, sustainability of healthcare in rural and regional remote areas, those kind of places in Australia. What do we need to do there? Are we doing okay?
I think we probably improved a lot in the past, but I think there needs to be a lot more coordination. From a practical point of view, from where I work, we get state-funded people coming to the clinic, we get federally funded people. Actually, sometimes we have over-servicing. We have, 1 week we'll have a physiotherapist, a podiatrist, a dietitian and a diabetes educator turn up. And people will come and see them and they'll get their feet done and they'll talk about their diet, and then a month later the same people will come and they'll go back and see them again, and you don't get that in the city. And then a few weeks later the ophthalmologist will come, and an optical dispenser and a social worker, and it's a lot of people coming there. I think we're doing pretty well actually, but even to the point of over-servicing in some places. But the thing is coordination.
Yep. Stephen, I know you had a view on regional, rural kind of healthcare, how it's set up.
So I share with Andrew that view. I was in Mount Isa for a while, and went out to one of the islands north of Mount Isa, and on the plane that I was going on, there was a physio from somewhere or other, somewhere else from somewhere or other. And the problem was, these people were fly in, fly out. There was no continuity. There was no trying to build up the skills of the people in those small rural communities, trying to, in my view, it would have been better to have a person who had a bit of a physio skill and a bit of an OT skill and who lived in the local community and worked in the local community and was there all the time, rather than a person who came in and did a quick fix and went out again.
And that's another interesting point, I think, is that, one of the things that I've thought about a bit too is have we got the right sort of workforce even for this sustainable healthcare? Should we be looking at new models? And what stops us from doing that? Sandy, do you have a view?
Of course I have a view. It's really interesting because, when I studied physiotherapy, I actually was the very last year at University of Toronto where physiotherapy and occupational therapy were together, so we kind of learned both, which was a good skill. And I spent most of my career as a physiotherapist working in home care. And when you go into people's homes, you can't take 15 different health professionals in. So I actually had to learn a little bit of social work. The social workers would hate me saying that. And I had to learn some basic nursing skills. So things have changed very significantly from when we educated health professionals with specific scope of practices. And I really believe that we need to be thinking about what it is the community needs. And maybe we need, as Stephen says, somebody that's got the skills to work in a rural community, somebody that's got the skills to work in primary care, somebody that's got the skills to work in palliative care, somebody that's got the skills to work in workplaces. And they're not a doctor, a physiotherapist, an occupational therapist, and a nurse, but they're a variety of skills. It's very hard to do because of all of our health professions have scope of practice. And we hang on to our scope of practice and we say, we're a physiotherapist or we're a nurse, this is what we can do and nobody else can do it. And so we have to think very creatively about ways of the future, things to do, to think about matching how we educate health professionals with the needs of our communities.
Okay, good. All right, so one of the other things that sometimes I hear too about sustainability of healthcare systems is that we perhaps because it's glamorous or interesting, we tend to spend a lot of health dollars on very few people at a point where they're particularly very, very sick, at end of life, for instance. Is that an issue? Is there something we should be thinking about there?
So we do handle end of life badly. So if you ask people where they want to die, I think 70% say they want to die at home, and the reality is 16 or 14% do actually die at home. And so there's obviously a mismatch between people's wishes and what actually happens. And so what we need to do is to invest in the support systems, because you don't want people to die at home alone. You want them to die at home without pain, in comfort, and so on. So we need to actually be providing services which allow us to do that and to support that. And
I think the thing is to have the conversations too. Many of us wouldn't know what our parents want. My children probably wouldn't know what I want. And so I think it's really important, and there's many mechanisms now available in terms of advanced care planning where you can begin to have those conversations. It's difficult to have those conversations, but when you're critically ill in a hospital, that's not the time to have the conversation with your family about what your wishes are. So we need to, again, be thinking about within the community, helping people to have those difficult conversations so that everybody knows what the wishes are. And if you do want to die at home without a lot of intervention, that people know that that's exactly what you want to have, and they're not going to call an ambulance for you.
So but initiating that conversation is hard for a doctor or a nurse or whatever, because often they're not trained to do it. And so what we suggested in the report we did on this called Dying Well was to have a publicity campaign, just like we had stop smoking campaigns, and have a campaign which would say, I think we got an ad agency to do a mock-up of what a campaign would be, and I think it was called Living It's a Dying Thing, or Dying It's a Living Thing, or something like that. But to try and actually get over the culture in our society where we can't talk about death and acknowledge that not all of us are going to live forever.
Okay.
We had an event last year where we actually celebrated the Mexican Day of the Dead, and we saw that as an opportunity because it's, in other cultures there are mechanisms in place that makes it easier to have those conversations as well too. So that's coming up at the beginning of November.
Do you think it's a fair or an okay thing to think about people who live in, I'm just going back to rural regional areas, they choose to live in really remote areas? Should they expect the health care that everybody gets? Should there be equity?
Obviously, you can't expect the same care. We can't have cardiac surgeons in far west Queensland. And you're not going to get the same. But on the other hand, we do have across Australia very good patient transport schemes, refunding costs and so on, and accommodation, and it's very good. You can rely on telehealth a lot as well.
Yes. Yep.
Yeah, just for a 5-minute consult, it saves a 1,000 kilometre drive, and it's a very good system.
Okay, good. All right, now one of the other things I'm noticing about this panel is they've had a lot of international experience. In fact, all of them have worked in other countries, and so we'll have a pretty good idea, I think, of what other policies from other countries, for instance, that might be implemented in Australia that would be a useful thing, particularly if there's no budget issue around this. What things, if each of you think you've learnt or seen in terms of policy where you've been, that actually would enhance our system here? Stephen, do you have one that you can think of?
So you always have to be very careful about importing ideas from other countries. I'm not saying you shouldn't do it, because I have done it in my career, but other countries have a different context, and something that might work in another country may not work in this one. But there are lots of ideas. One of the ways I worked as a manager was to keep my eyes open for other people's ideas and to steal them shamelessly, because people write things in journals. Journals used to be these things with paper and things like that, but blogs and so I get all these feeds now. But getting ideas from other people, and sometimes one of them, for example, that I've used in one of our studies was there's a group in Boston called the Institute for Healthcare Improvement, and they have developed a waste identification tool. And it's a very simple tool. It just involves someone wandering around the ward and saying, is this bed empty? Yes, no. If it's empty, why is it empty? Is it because there's a delay in care being received or whatever? And it helps you focus on trying to look at the system and the process of care and all those sorts of things. And so there are lots and lots and lots of ideas you can pick up from overseas, but you've got to think about how you apply them here.
Okay, good. Sandy, anything from you?
I guess one of the things that's baffled me, and it happens in many countries, is that we have different levels of government that are involved in the public healthcare system. And so it seems to me that if the national government is worried about doctors and drugs, and if the state government is worried about hospitals, there's no real incentive to put it all together and to be able to say, let's make our doctors work with the hospitals so that we're not actually having people end up in the most expensive aspects of care. And so those countries where they actually look at a population, look at possibly a geographic population, and say, for this population, we need these many GPs, we need these many primary care nurses, we need these types of services, so that we can actually have a service package that provides right care, right place, right time, and is not kind of left to default. I think that would be a good thing for us to consider. But it's very hard when we have, three levels of government in Australia playing in the public healthcare system.
Sure. Andrew?
I worked with a lot of Scandinavian medical staff in my work overseas, and I said to one once, I suppose you've got pretty good private cover yourself, and she was astonished. She said, what are you talking about? We don't have private hospitals in Norway. Everyone's got the same care wherever they go, and as Stephen said, it's kind of a folly to think we can just import other people's ideas, but maybe something worth looking at. There is a disparity in this country with the haves and the have-nots, and again, it's a political issue. So
Okay. So that does raise the issue of what place does the private health sector play in our system? Is it's important? What do you think, Stephen? What part should it play?
So about 47% of the population has private health insurance. If about 60%, I think, of hip replacements are done in private hospitals. Sorry, 6% of less complex hip replacements are done in private hospitals. And about, I think it is 20%, I can't remember the exact number, of more complex hip replacements are done in private hospitals. So if you have private health insurance, you have a better chance of having a hip replacement. Now, I don't necessarily want a hip replacement at the moment, but some people might, for entertainment, want to have a hip replacement, and if they do, they should take out private health insurance. So there's not equitable, if you assume that it may not be a valid assumption that the populations are equally sick, but there's something funny if 60% of the less complex hip replacements are done in private hospitals and only 20% or 30% or whatever it is of the more complex hip replacements are done in private hospitals. There's some distortion in the system that's going on. And so there's obviously the market is not working to actually make sure that if private hospitals are going to do hip replacements, they should do all of them, and not leave the more complex and more costly and so on to the public hospital system. And similarly, that people in the public hospital system have adequate access to hip replacements and don't have to wait in pain for years.
Yeah. Sandy?
Just building on that a bit, private hospitals don't do trauma. Private hospitals rarely have emergency departments. Private hospitals rarely have pediatric units. Private hospitals often don't take older people who may not be discharged as quickly as younger people for their hip replacement or other things. So that makes me think that what's actually happening is that the private hospitals are doing the easy things that can make a lot of money, and the public hospitals have to do the very difficult things that cost a lot of money. And they don't get the benefit of having some of the less costly procedures to increase their revenues, where patients turn over quickly. So there might be a concern that because we have a healthy private hospital sector, it's making our public hospitals even less competitive. So that's just something that I wonder about in the system. Mm-hmm. The other thing that I wonder about is we actually did a study with a group of heart patients a number of years ago, and they'd all had excellent cardiac care at an excellent private hospital. But when we interviewed all of them, they all said they didn't realize how much it was going to cost. They'd been paying their private health insurance year after year after year. And then when they had their cardiac event, they still had to pay for tubes and stents and surgeons. And so they got these massive bills when they came out of the hospital that they didn't realize that they were going to get. So in many ways, our private health insurance system, we don't know enough about it to be able to make the right decisions about it, I think, and we often get caught on the fly because when we become sick, we don't realize that there are extra costs involved.
Yep.
they
Andrew?
might get an operation in a private hospital and get some complications and then be transferred to the public hospital where there's a doctor all night.
Mm-hmm.
And again, this distorts the thing as well. So
Yeah, okay. Some of you have talked about this a little bit already, and that's health research. So thinking about health research that's happening now, what do you think is the areas, what are the areas of health research that are having the most impact on current policy? What things are influencing what our leaders are doing.
If I can, I'll start with this one and then you can come in. I mean, one of the things, we get a lot of research funding from government organizations. So the National Medical Research, Health and Medical Research Council funds a lot. And they fund a lot of really excellent clinical research that actually changes how we provide clinical care, and we find new drugs. And we're always improving those technologies from the research funding that comes from that. But the basic issue that I started with about babies dying because people didn't speak up, or because people didn't have the systems in place to track the numbers, or because people hadn't defined what a quality of care, what quality of care looked like in their organization, so that they could tell if they were actually providing quality of care. There's very little research funding for that type of research. And I think that's the type of research that's going to improve our experiences with the healthcare system in the future. So I'd like to see more investment in those areas so that we can influence policy in those types of areas. We want to keep doing the cures, we want to keep doing the great technologies, but we also want to think more about how we push the system, because that's what the policymakers need to know in terms of making policy for the public healthcare system.
Stephen, what do you think?
Karen, it's a very complex question. So the vast bulk of the research, I agree with Sandy, the vast bulk of the research that's done in Australia, 95% of it, will have no impact on patient care in Australia in the next 5 years. It's not designed to. That's not what the claim is. Sorry. Despite what you might read in the newspaper where the breathless announcement occurs, 95% of the medical and clinical and health research that's done here has no impact in the next 5 years. Probably 50% has no impact in the next 15 years. But again, that's not what it's designed to do. It's designed to advance world peace, or something or other. Or
to
create
use some
employment.
really cool technologies.
Use a machine that goes ping, or to employ new graduates. I mean, the health and medical research system is really a very, very peculiar system. But as I said, I'd agree with Sandy that if you want to, there's some research that can only be done in Australia, and that is how to make the Australian health system work better for patients and taxpayers and so on. And that there's certainly an underinvestment in that research, in that area. And I can speak as someone who is not allowed to, as part of my employment, apply for research grants in Australia. So I've got no interest in this issue.
So why don't we invest in that area? Clearly important.
It's. I think the systems and the structures are biased against it. Sandy, do you want to?
I think it also goes back to our discussion about the longer term benefits and the working in an organization. So much of our research where we're actually, and I should talk, we have a really interesting project now where we're actually following the implementation of quality systems in 8 hospitals in Victoria. And we're finding amazing information about what hospitals are doing and what they're not doing, and a bit of a divide between what the board and senior management think is happening and what's actually happening in care delivery on the ground. Now, it's going to take us at least 3 years to find those findings out, and the system keeps changing. So every time we go back to the hospital, there's a new policy, or the funding model has changed, so unlike having a clinical trial where you can kind of make sure that you're testing a drug and you've got controls and you've got the ability to actually see if the drug makes a difference, there's an awful lot of things going on in the real world that make it difficult to actually do that type of research in healthcare. So we're trying hard, we're trying to make it happen, and we're just recognizing that, each time we do this, there's a new standard, or the accreditation system has changed, or some new policy is out there, and we're trying to build it into our research. But I think people that don't understand that that's the type of research that has to be done, and are used to clinical trials and are used to new drug trials, find it difficult to see how they can fund something that takes that long and is that complex.
Nothing anything further to add.
So I suppose it's an interesting point. Let's be controversial here. So should we change the research funding and just cut it from what it is now? Should we be investing in other things that would make a bigger impact on health? It's not about funding research on machines that ping. What do you think?
A lot of it's got to do with where the funding is coming from.
Yeah.
There's a lot of private funding as well from drug companies and so on.
That's true.
Some have had major implications, like the Helicobacter study, which prevented thousands of abdominal operations. And
Yeah.
But the good news about that study is the guy who applied for it didn't get his NHRC grant. They wouldn't fund it because it was too wacky.
you get a Nobel Prize at the end of it.
But you got a Nobel Prize. So, yeah, no HMRC grant, but a Nobel Prize. Karen, I think I'd start differently.
Yeah.
Any sensible organisation needs to invest in innovation, otherwise, and especially in any sensible organisation needs to invest in R&D, in innovation, and so on. And the issue is, how do you do that investment? How much do you invest, and what sort of are your priorities? Mm-hmm. So I haven't said that I think that the money is wasted in research. I haven't done any work to analyse that. Although we did look at some research that was funded by NHMRC to see whether it had an impact. But I think it's a matter of priorities and what sort of research is funded, and what return we get on that. And I don't think we've done enough work on that.
All right, at this point, I'd like to open it up to the audience. So have we got a question from the audience? Yes, we do already. So we've got somebody...
Don't sound so surprised.
No. I thought that they're dying to ask you a question. You're in trouble now. So if you can say who you are and where you're from, and then ask.
Hi, I'm Ellie Newnham from Deloitte Access Economics. I was just interested in gathering your thoughts on I guess the main drivers impacting the future of the healthcare system around, I guess, the ageing population, the rise of chronic illness, and also the impacts of technology. Mm-hmm. And just get your thoughts on, I guess, the interplay of these factors and how it will impact both the private and public aspects of the healthcare system.
That's a big question.
I think the health economist should answer that one.
So, since I've been labelled as a health economist, in terms of, if you look back over the last decade or so, the big drivers in cost have not been ageing, have not been population growth. So ageing has had a small impact on health costs. The big driver of cost growth across all areas of health expenditure has been changes in the way we do things. So at every age, so for people in their 30s, we now have more health interventions, more diagnostic x-rays, more pathology tests, more drugs that are used. And so the big impact on health costs has been change in services. Now, what's interesting about that is that associated with that, not necessarily caused by that, but associated with that, there's been an improvement in life expectancy, there's been an improvement in what's called amenable mortality, mortality that can be influenced by the health system and health interventions. So things are happening associated with this increased spending. And that's been the case for the last decade or so. Looking forward, do we expect the same sort of patterns to be happening in the future? Certainly, the health system itself has not adapted as well to changes that have been going on around us. If you think about a 21st century health system, for example, you'd expect it to be more adapting to technology, information technology, or change in the complexion of disease. So our Medicare system is very much still fee-for-service based, which is quite appropriate if the illnesses are all acute and so on, but questionably less appropriate if we're dealing with chronic illness. So the system itself isn't adapting well to the changes in the environment around us.
Okay. Do you want to build on that? Anybody else? No?
I think he's answered it really well.
Thanks, Steve. Another question? Have you got this question for the audience? Yes.
I'm a nurse. I'm general trained. I've got issues at the moment with APRA because I reported a health practitioner.
We probably shouldn't talk about personal
Yeah,
things
but anyway.
here, I think, because we are recording things, so it'd be
Okay,
better
that's
if you
fine.
didn't actually talk about anything
Yes, but anyway,
personal.
that's good.
Good question.
Anyway, coming back to the point is the private sector allowing caesarean sections, women demanding them because they've got to go back to work, whereas that doesn't happen in the public sector. And I know that from experience from a relative, a married-in relative. Another thing is the public sector. I went with the Cryosite umbilical cord collection, a Sydney company, private company, where I saw a lady in labour for 72 hours. They'd already started medications. They allowed her to go 72 hours without giving birth. I was nearly...
So what's your main question?
She was taking up a bed for 72 hours. She
Yeah.
hadn't given birth within the designated. Once you start a
Yep, sure.
medication, a drip, or you place lubricant between the vulva. She was in the healthcare of animals. I don't know if that was the reason why it took 72 hours to give birth.
So is the question around the differences between
That's why-
private and public?
What I'm saying is, if you allow a person to demand to have a caesarean section, there's usually in the public sector at least 10 people, 12 people in the room in the theatre. So that's why it's costing a lot of money.
Okay.
Compared to just giving birth, there might be 2 people, one the nurse and the family
so
member.
the questions around the use of technologies, I
Yeah.
think, in
So
health.
there's a lot of discrepancy using. There's no universal health system giving birth.
Okay.
I think, and that this is probably a good example that, C-sections on demand or some of the other things that there's within the healthcare system, there is probably a lot of things that we still do that aren't necessarily associated with best practice that we're still doing. And I think Stephen talked about the waste tool, and I think the waste tool doesn't just pick up, when patients are waiting or there's waste in the system, but when we might actually be providing care that's not found to be effective. And so I think it is an important area that we need to be thinking about in the future, and we need to be thinking about what are the tools and what are the areas that we can be making sure that we're spending the limited amount of resources that we have so that everybody gets the best care. I'm not sure that we're quite there yet to be able to do that, but I think you raise an important point.
Yeah, that's good. Another question? Yes.
My name's Libby Mitchell. I'm with La Trobe. I just have a question. You've referred, everyone has referred at some point to various kinds of social marketing programs or health and public education, health interventions, so anti-tobacco, anti-smoking, seatbelts, so forth. So when I was in the United States, there were lots of avenues for building research about health interventions and social marketing programs into grants that were going through CDC, getting CDC funding and other kinds of funding, and I haven't seen very much evidence of that in Australia. And part of the issue that I wondered whether you have any observations to make as to how we could do a better job of building evidence around the effectiveness or the efficacy of social marketing, and perhaps that would be a way forward with more of that happening in Australia rather than less.
The Cancer Council has actually done a lot of good work over decades on evaluating all of its campaigns, and similarly, they've had a group of very competent researchers, but generally funded by the Cancer Council, generally not funded. So it's the issue you're raising is a good one, I think, that we tend, and it does link to some of the earlier discussion we had, that we tend not to be doing the research about what works in terms of social marketing and what doesn't, and incorporating social marketing campaigns into the system. But yeah, so you're right.
And I have some examples of some research that we're currently conducting at La Trobe in the Building Healthier Communities. One is actually a group of students in mathematics have actually come up with a portable fetal monitor that they're thinking might be useful in rural and remote settings, that it's something that links with a phone app. I don't understand the technology, but it just sounds like it's got an amazing...
That's a phone.
But I don't know, the baby phones you or something. Counts babies' kicks or something. And the other thing is that the people that work in the Olga Tennyson Autism Research Center are also working on an app, again, on a phone, that helps people to think about symptoms or signs related to being on the autism spectrum. So we've actually got a fair bit of research in this area looking at trying to develop, not so much the social marketing, but looking about how we can get information out to people to make it more accessible for them so they can start to think about their own healthcare decisions and what they want to do in terms of contacting professionals or making decisions on their own.
And also it should be placed more heavily on doctors and nurses and other clinicians that should take these opportunities to educate people when they see them, not just have a campaign one week on this particular topic and another one next week on a different one. So as we see people in our practices, to go over what might be pertinent to them, for obesity or smoking or sun safety and so on. And in Germany they have an interesting system of health funding is for GPs, largely through insurance companies. The doctor will get paid so much per month per patient. So it's in the interest of the doctor to want to see that patient as little as possible. So they're going to do their best to try and keep them well and keep them not to come so often. I think it's similar in China as well.
Okay, good. Yes, do we have another question here? Just here. Gentlemen.
Thanks very much. My name is Graham Little. I'm a health politics lawyer who grows medicinal herbs on his farm in French Island, including arthritis drug, non-drug called comfrey. But my question, my point on what's happening with the system and why it's out of control, I believe it's heavily skewed to the interests of big pharma. I've done a lot of work in this area. The polypharmacy approach with a rapidly growing number of drugs that each patient's getting, which I think in the US is now running at 11 per person. Certainly nursing homes, it's running at about between 10 and 15 drugs. On admission, we've got monopoly protected situation for their drugs, which we're extending out with the TPP, which no government will tell us exactly what deal the drug companies are going to get a better front. Almost no consumer at the chemist realises that the rest of us are paying 488% tax when they buy a chemist item. That's the PBS system, $9 billion. Everyone I asked guesses somewhere less than 100%. But the markup is 488% to the drug companies who pay no tax. There's been massive corruption cases for 15 years in the US. We haven't touched it, and there's no government body interested in doing it. And finally, I believe there's an organised conspiracy to actually slow the growth of natural medicine practitioners who get no subsidy, don't get a look in on research, and more the public wants to go and see them. So that's why I think it's out of control. Thank you.
Yeah, I think the PBS is very interesting. I mean, Australia is one of the few countries in the world that has had a pharmaceutical benefit scheme for so long. It was introduced in the 1948 initially, and it has a number of strengths, and including making drugs available at an affordable price. People in Canada would just dream of it. I mean, there was an election in Canada this week, and the new government has promised to do something about making drugs affordable for everybody. On the other hand, as you rightly point out, Graham, we pay way too much for some of the drugs that are on the pharmaceutical benefit scheme. We did some work a couple of years ago where we compared the prices paid in Australia to the prices paid in New Zealand, and we were told that, and we paid, I think, 5 times on average more than the New Zealanders, and we were told, by the big pharma, that's hopeless. New Zealand's a third world country, so you can't compare us with New Zealand. So we then decided to compare us with some other countries, England, another third world country, and Canada, and we got the same result. Anyway, they didn't use that argument anymore. And then we did another study which looked at comparisons within similar drugs, and again, we're paying way too much. So, and it's all... So there's lots of areas for improvement in the pharmaceutical benefit scheme. I don't really want to go into the herbal medicine versus everything else, but it is an area where we do need to improve.
Comfrey grows well in Bursville, by the way. The locals call it knit bone. It's an old English term.
Okay, another question. Yes.
Hi, my name's Danielle. I work in healthcare strategy. You spoke earlier about international research and sort of systems. Some of the, I suppose, research that's come out from the US is around value-based healthcare and a move towards accountable care organisations. I suppose the underlying principle to something like an accountable care organisation is the idea of having integrated care. And in Australia, I guess we have very fragmented care for patients. How do you think this is a way forward for healthcare in Australia? And if so, what are some of the steps you think we need to get us there?
So the major success in the United States about accountable care organisations has been actually getting the doctors and the hospitals to be paid in the same way, which is something we have done in Victoria for 20 years. The second thing they're trying to do and having less success at is that integrated longitudinal approach where they might bundle the care before and after. So if you have a readmission, for example, then the hospital is responsible for payment for that readmission. So I think that has all sorts of good incentives associated with it, which are worthwhile learning from. The issue of value-based healthcare, I think, is a really important one. And just to give you an example, I'll give you two examples. In Victoria, we pay hospitals on the basis of their activity, and we bundle that payment into what are called DRGs, diagnosis-related groups. And so if you go into hospital for an operation on your stomach, you get paid a particular amount of money. An appendectomy, the hospital gets paid a particular amount of money for it. If something goes wrong during that operation or during your care, and you have to stay a few days longer in the hospital, is it reasonable that the hospital should be paid more for that or not? That is, should the hospital get paid more if something goes wrong or if it doesn't go wrong? Who thinks the hospital should get paid more if something goes wrong? 2, 3. Who thinks the hospital should not get paid any more if something goes wrong? So about 3 times or about twice as many people think they shouldn't get paid. But this is a really interesting question because it's about, to what extent should value or quality be taken into account? Another way of phrasing that, in England, if you have a hip replacement, before you have the hip replacement, you will be asked, how much pain are you in? How much discomfort? How difficult is it to walk? And then after you've had the hip replacement, they'll ask you the same set of questions so that they can measure the extent of improvement you have in reduced pain or improved mobility and so on. And so they actually do publish on the web, this hospital, named as that hospital, is better than the English average on improving people as a result of their hip replacements, or is worse than the national average in terms of that. And so we're beginning to actually talk about the outcomes of care, and I think that's a direction where we should be going.
And I think the thing to add here as well is that although value-based healthcare actually has those aspects that Stephen's been talking about, the fact that we're having really good discussions about patient-centered care and organizations are beginning to refocus, because we've always been focused on the needs of the doctors and the staff, and actually thinking about truly becoming patient-centered or patient-focused or client-centered or customer-focused is an important area for us, which also I think is going to help us to have some of those value discussions. What's of value to the patient. And with the implementation of the National Disability Insurance Scheme, where individuals control their own funding and can pay for Comfrey if they want to pay for Comfrey instead of paying for physiotherapy, that's the beginning, I think, of us trying to figure out what actually value-based healthcare might be in the Australian context.
Just a word of caution as well with this type of funding is that was part of the Jayant Patel case. That hospital was the managers were, I believe, encouraging the practitioner to perform more and more complex operations to get more funds, and it's got its drawbacks. So.
Yep. Okay. Probably got time for one more question. One more question from the audience. Yes, Bill?
Bill McGuinness, Head of School of Nursing at La Trobe. I want to go back to that notion of the generic healthcare worker, because I would actually argue that I see a lot of clients in my practice in residential aged care. I'd argue that we actually have an abundance of the generic healthcare worker or the semi-skilled worker. What we're not doing is scaffolding the care so that when those people need assistance, there isn't the referral mechanisms or the wherewithal to get the need then and there, when I'm often asked to see clients that are well down the track and probably are beyond my help in some instances where I could have done something earlier. So I was wondering if the panel could comment on how do we start to really get this notion of not having semi-skilled as a cost containment, but really having a strata of care based on need and how that links with each other to meet the patient outcomes.
Who wants to take that?
So, Bill, what do you think?
I've been working with a colleague in Singapore, and he sells apps to maids to look after old people, right? And when the old person's got diarrhoea, you buy for $2 the diarrhoea app, and it gives you a few things to run through. If it doesn't help and the person's still got diarrhoea, there's a button you push that goes to a call centre, and the call centre then talks you through some support. And if they think you actually need clinical services, they then refer you straight onto a clinic. So, and you pay for every one of those, as a user in Singapore, you pay for every one of those consultations. But what he's got is a strata. And he now has navigators running around in China, and they have a camera on their shoulder. And so when they're working with the patient, and you can do that in China because people can be filmed and not object to it, I presume. But when they're working with the patient, if they need to get to bill because the patient's got a wound problem, they can hit the button and I'm seeing what's there off on my phone while I'm out on the golf course or wherever, and can actually provide that sort of... So it's about using different access opportunities so that we can strata around different types of opportunities. But interested in thoughts.
So my response, Bill, is that you can only have these multi-skilled workers if there is appropriate supervision and support. That is, that there's the risk is that they'll start doing things that they're not trained to do, or they, or that they realise that this is the limit of their skill, and there is no one for them to turn to. So that's the critical issue. We have to make sure that implementation of this is not just random, everybody does whatever they like, but there's a structure and a supervision and support.
Yes.
And I think nurses have become very specialised nowadays with increasing bodies of knowledge of everything. My mother was a nurse a long time ago, and she studied, part of their program was dietetics, and then they had physiotherapy. There weren't such practitioners in those days. Now we've become so specialised that the nurse is going, I can't talk about that, it's got to go to the physiotherapist, or we better see the dietitian, or so on. So I think, it's maybe the nursing programs have to be more rounded, and maybe it's something for the nursing department.
Do you have anything else to add, Sandra? No? No? Okay. All right, well, I'm going to take the prerogative of chair to ask the very final question, which will be to each of you. What I want to know is if you could make a change or do something to improve the healthcare sector in Australia, and that could be quality or whatever you think it is, what would that be? Stephen, what do you reckon?
Karen, I don't think that... Well, there's lots and lots of things I do, and the point of that answer is I don't think there's one big quick fix that we want to that I want to pursue. There's lots and lots of things. Some are system changes. Some are local things in local hospitals to do things differently. That the major transformation of the health system is not going to be a single big bang, but it's going to be inch by inch or centimetre by centimetre change to improve the experience of people, the measurement of what's happening, and so on.
Good. Sandy?
I think I totally agree with Stephen that I think there's a number of different changes and different levers at different parts of the system. But I'd really like that to see in a couple of years that every one of our healthcare providers actually has a definition of what high quality care is in their in their context, because we can't measure it if we don't know what it is and if we haven't defined it. So you know, just like with I got a new phone. I had an iPhone 3 and I finally got a Nokia that does a whole bunch of whiz-bang stuff. And you know, Telstra's the provider, and Telstra knows exactly what services you get for what money and what, you know, what the quality is and all that kind of stuff. The hotels, you know if you're going to be in a tiny little room with no supports or a palatial suite based on what you get. So we can define quality very easily for other services, but we do not do it in healthcare. And so I'd really like to see that every single board of directors has a definition of what quality of care is, high quality of care is in their organization, and they're measuring it and they're holding staff accountable to achieve it.
Andrew?
Probably for me that is to look to the future and see what the next predictable epidemic might be, whether it's obesity or an infectious disease like influenza. Just as an example.
Great. All right, well, I'm going to wrap it up there. I think I've learnt a lot. Thank you very much, everybody, because I think one of the things that I've learnt about is that maybe we're a bit over-dramatising the crisis, that we actually do have some control on what's going to happen, because maybe the biggest impact we can have is these incremental changes. And I think the other thing that we've learnt, or probably most of you know, our health sector is really good. It's in good shape in compared to international standards, and we're doing pretty well. There's things we could do to improve, and we've talked about a lot of those things as well. So I think it's been a really interesting night. La Trobe University, thanks very much, Melbourne Knowledge Week, because it's an excellent opportunity for us to engage with the community, which is a really important thing. So thank you very much for that. We're really glad that you could come. I'd like to thank the panel very much. So join with me to thank the panel.